like to welcome to the stage Darren Deason.
Thanks, Martin. It kind of makes me sound like a hobo. I moved around a lot. Not quite as much as that, but I want to bring you back to 1995. I graduated from dental school in Oregon in 1995, and I didn't do any residency. I went right straight to work. In fact, I went to work with my family dentist, our local dentist, small town in Astoria, Oregon, and I'm there for 6 months or whatever, doing what associates do in 1995. I'm spinning down teeth, making crowns, and I'm doing amalgams, and I realized this isn't really what I wanted to do. So I left that practice and I made a startup practice in my hometown, Gerhardt. And Gerhardt is beautiful. It's right on the beach in Northwest Oregon, beautiful. And it's perfect because there's nobody there. It's like 1,000 people there. It's great. And unless you're trying to have a business, then it's a bit challenging that way. But that's where I opened my first practice. And pretty soon I get a patient like this that walks in. And in 1995, I just graduated from dental school, and I'm feeling pretty good about myself. I got amalgams down, I got crowns down, and I see a patient that's not this patient because I didn't have a camera. So I can't show you the exact patient, but the patient looked just like this. And so what did I notice in 1995? She has short teeth. Okay, 1995. What's in my toolbox for dealing with short teeth? I got crown lengthening, and it's 1995, right? So I've got veneers. So crown lengthening and veneers. Open a new practice. Who am I going to refer this to for crown lengthening? I live in a small town on the coast. There's no specialist in my town or even in my county. So I'm finding the closest periodontist to me, 60 miles away, and I'm making a note like this. I have no idea what I'm doing. I recognized that the teeth were short, and all the journals were telling me that I should be doing veneers. Okay, please evaluate for crown lengthening. I mean, seriously, I might as well have said this. Do perio. So I get a call. I get a call from this periodontist, and he says, I'm not really sure what you're asking me to do. I'm like, well, what do you mean? The teeth are short, make them longer. Normally the guys will give me some kind of a guide or a matrix or, maybe even a drawing or something, and I'm like, how do they know what to do? How do I learn that? And he said, I don't know. Okay. Seriously, he didn't know. So what was I asking him for? I was asking him for collaboration, and I was asking him for mentorship. I was asking him for guidance on the case. I didn't use those words, but it's exactly what Martin was talking about this morning. I was looking to this soon-to-be interdisciplinary relationship, and I was looking for some guidance from this person who, because of his position, I thought would be able to tell me what to do. And he couldn't. So how's it going to work with a case like this if I want to use implants? This, like a crown lengthening case, or maybe going back, if you remember how triangular shaped those teeth were, to crown lengthen that and then try and restore that with veneers is going to be really challenging. But I didn't show you any pictures of the face, so how do you know where the teeth are supposed to go? I didn't have any information. There's no way that surgeon could have helped me. Besides dumb luck. So a case like this, what are you going to do? You think, well, the patient's a dentulist or soon to be a dentulist, and I want to use implants. So 1995 skill set, what's my referral slip going to look like? Place implants? Seriously. So one of the things that I'm trying to do with the curriculum that we're building and the modules that we're building for the study clubs now is give you guys all some tools to help answer these questions when people like me in 1995 are looking for guidance. And so what we passed out just at the break is one of the tools that we've been using. I started to implement this in the edentulous arch workshop, the last go here, so it's a couple weeks ago. And it's a tool that would help me as the dentist that I was in 1995, or really even the prosthodontist that I am now, have an idea about the information that I need to bring to an interdisciplinary meeting, a patient conference. So if I'm going to organize, now I've just moved to Scottsdale, I'm still building my interdisciplinary team here locally. So if I'm going to sit down and meet with my interdisciplinary team, what kind of information do I need to bring to that meeting? What should people expect from me? And so let's walk through this thing, because I think you may find that it's helpful. This is Anthony. Anthony's a module that's going to be released here pretty quickly. We've shot the first part already, and it's been edited, so you'll see the first part pretty soon. The second part I'm going to shoot in December. But Anthony's got an existing overdenture on the maxilla, and he wants to change it. So what do I need to bring to the conference? Well, yeah, I need to bring basic stuff. So obviously patient name, but really I need to bring to my interdisciplinary team the outcome that Anthony's looking for. So we've got a quick reference for, okay, remember, no, he doesn't want anything removal or whatever. But we just want to have a quick way to get back to the conversation that we've had with him about where he wants to go with his treatment. The next thing that I need to do is I need to identify who are going to be the players on this team. Because I know that Anthony's case is going to be complex, and the reason that I'm showing this interdisciplinary kind of conversation stuff around an edentulous arch using implants is because those cases are all complex, and the penalty for missing something in your treatment planning, the penalty can be so severe. The cost for the treatment that we're going to do for Anthony with the full maxillary zirconia prosthesis, in my first practice in Gerhardt, if I had to eat that, the lab fee alone is close to $15,000 for one arch. So if something doesn't work out and I have to eat that, that's going to have a huge negative impact in my monthly production, right? So I'm going to have to explain that to my family, like, yeah, sorry guys, no gas, no food, no nothing this month. So I need to identify who are going to be the right people for a case like this. And so we need to identify who's going to be the restorative person, who's the right surgeon for this case, and critically important, and we say this at all the workshops that I'm involved in and everything else we do on campus, is we need to identify who's going to give our technical support for this case. Who's the technician that we're going to be able to rely on? And I want to identify that person early on in the process so that we can get information, we can get feedback about the case and the diagnostic information that we need and the restorative planning that we're going to need. And we get the technician on board with that straight away. So if there's going to be a problem with the technical work or something that won't work, we know that before we get too far along. And so this is Anthony's maxilla. He's got an overdenture. It's a complex type of an overdenture. It doesn't move very much, but there's some things about it that he doesn't like. As far as this treatment planning form goes, what we need to identify is where is it that we're going to be working. So we know the patient, we know what the patient wants, we know the interdisciplinary team. What's the field that we're going to be playing on? And so in Anthony's case, it's the maxillary arch. Okay, easy enough. What are we going to do with the opposing arch? Because do we have like complete control over the upper and the lower jaws? Is it limited to one arch? And if it's only one arch, do I have control over the lower arch because I'm planning on doing some more restorative work? Or is it really going to just be limited to one arch? Because from a surgical point of view, that may not be as difficult to deal with. But restoratively, if I have to treat a complete arch like this and I don't have control over the opposing arch, it can be much more difficult. In addition to that, and what we're going to see with Anthony is that on the lower arch, the prosthesis that we're going to design for him is going to be opposing not just natural teeth, but natural teeth and implants. And so I need to be thinking about my prosthetic design in a way that's going to deal with the increased forces that that prosthesis is going to be subjected to. And so we need to know that as we're having our conversation at this interdisciplinary conference, right? I can't, as a restorative person, I can't expect that my surgeon's going to be able to say, hey, what about that lower arch? You think you're going to get another couple implants down in there someday, or that curve's okay with you, you're fine? No, that's my responsibility. Next thing, we want to evaluate the existing prosthesis. And you guys as surgeons, or you guys as prosthodontists, or you guys as GPs, or whatever your role is on the team, you guys have to expect that someone has critically evaluated the existing prosthesis. Because in Anthony's case, we need to evaluate the aesthetics. That's always true. But in Anthony's case, there's a midline discrepancy. And if we trust that this is where the teeth need to be, and we then plan our implant position based on where these teeth need to be, that could be a problem for us, right? Depending on the prosthesis. If it's an overdenture, who cares? But if this is going to be some kind of a zirconia prosthesis or a conventional crown and bridge approach, this can be really problematic. So we need to evaluate the aesthetics, and not just the tooth aesthetics when we're thinking about a full arch, but the pink aesthetics as well. And so in Anthony's case, he wants to go from a removable overdenture to something that's fixed. So we have to evaluate the tooth position and then evaluate how the lip is going to relate to where the teeth are. So we've duplicated his denture, we've created a trial denture, and we've removed the flange to make sure that we've got an adequate lip support for him. Someone's going to look at the function, and that's really going to be up to us on the restorative side. And this is not Anthony's case now. This is another guy that I saw in LA who's very similar to Anthony and destroyed everything that I ever made for him. And he gave me a lot of clues. This is the initial denture that he came in with. And you can see there's a crack beginning right between the maxillary centrals. Maybe you can see the wear that's happened on the posterior denture teeth, and then they've been rebuilt with some composite or maybe acrylic there to try and kind of recover the vertical dimension. Well, this is the previous prosthesis that he had. He just didn't like, but you can see that somebody's been struggling with the fact that he's been breaking prostheses for a long time, and really went through some kind of fun, I guess, lab mechanics to try and build a mesh in there to try and reinforce this in a way that's going to help to kind of hold everything together. But looking back at Anthony's case, if I have this kind of information, like if I'm looking at a person who's wearing a complete conventional denture and they're destroying that, I got to be thinking there's going to be a lot of force going on whatever kind of prosthesis that I'm going to put in there. And I need everybody on the interdisciplinary team to know that so that we're all on the same page and we can share with Anthony that, hey, you know what, this is going to be a little bit risky. And if or when this breaks, it's not a surprise. We saw it coming. And if it's just me as a restorative person that 5 years later or 3 months later, the prosthesis is fractured and I'm like trying to explain, well, look at these dentures, of course you were going to break this. That's an excuse, we all know that. But if we have the ability to leverage the whole interdisciplinary team on something like this, it can be really powerful and really helps our patients along with their expectations about the care that we're trying to provide for them. So the next thing on the checklist here is we need to determine the restoration that we'd like to place for the patient. And this is really like, I think this is up to the restorative person, but this is the information that we will need to bring to the conference, and we need to talk about it. And if it's just one thing that you have in mind, if all you're doing is metal acrylic hybrids all day long, that's easy because you have one solution. What I would hope for and what we shoot for in the edentulous arch workshop is we'd like to give patients lots of different options. And so it could be that this is going to be a zirconia prosthesis, or maybe it's going to be another type of an overdenture. It could be a simple overdenture, like a 2-implant locator overdenture, or something more complex. But we need to understand that there are a lot more than just one option for dealing with an edentulous arch. And each one of those prosthetic options requires different amounts of space. Different amounts of vertical space, different amounts of horizontal space. And they're going to have like big differences in lab cost. And so we want to identify if this is going to be like, let's say, a hybrid. Are we going to have lab support there, and who's going to be the technician that's going to be there on the day of the conversion? I want to know that straight away. If it's going to be something different, then our lab support's already been identified early on with the first section where we were identifying the team. So we need to identify the implants that we want to use. And my bias is that the restorative person should really be involved with selecting the implant type and family, because that's ultimately going to end up in my office. And if I can limit the amount of prosthetic supplies and screwdrivers and bits and pieces that I have in my office, my life is much easier. And so to me, what's important is the prosthetic connection. I need to know where the implants go, but as far as determining the implant, it's the connection to me that's important. The length, is it tapered, the surface, that kind of stuff, we'll have a discussion with the surgeon about what's going to be most appropriate for the case. But we need to figure that out, right? I don't want it to be day of surgery, the implants are going in, and I find out that it's a completely different manufacturer that I have to retool for. So I need to then determine how many implants we're going to need based on the restorative design and where they're going to go. So I want to have a quick way that I can share that with the other people on the team. And so it may be something that's simple, like a 2-implant overdenture. And so my conversation will be something like, hey, you know what, there's a lot of sort of flexibility in where these implants go, but it's critical that they're parallel. So we can move kind of around the arch, no problem, I'm cool. But for the overdenture, we've got to make them parallel. But if we're going to do something on the maxilla, like with Anthony, where this is going to be a fixed prosthesis, we're going to use basically an entirely zirconia prosthesis, where the implants go is really critical. And so this is a tool that allows me to share that information with the other people on the team. How critical do we need to be in terms of the precision of the implant placement, right? So the next thing we need to talk about, what kind of imaging are we going to need on a case like this? Maybe it's nothing, maybe it's really sophisticated stuff. And the imaging that we're going to need is going to need to then go into some kind of a planning software. So which software are we going to use? Because I want to make sure that my scan is compatible with the software that we want to use. Am I going to need a radiographic template? And if so, based on the way that we're thinking we want to sequence this case out, or the way we're going to work through this case, is there some specific elements of the radiographic template that I need to include? Are there fiduciary markers that I need to incorporate in here, or do I just need to do something more simple like what I'm showing here, where I've got some tin foil on the teeth so that I can bring the tooth position into the scan data? And ultimately, we need to decide on which type of a surgical guide are we going to need for the case. I was backstage and I saw the blood, you know, from Robley and Curry, and I'm like, I'm so happy I'm a prosthetist. This is awful. So it's like, yeah, I don't want to see this stuff, but we got to think about the surgical plan. So do we need, am I basically going for, I need a lot of reduction because I'm going to need some prosthetic space, or is it a case where I'm going to need to augment? And how are we going to load the case? So this isn't, don't mishear this. This isn't me telling the surgeon how to do the surgery, because honestly, I don't care. I just need the implants to be where I need them to be in order to support the prosthesis that we're trying to design. But I would like to have an idea of what the surgeon's thinking so that I can help support that thought process when the patient has questions for me. We got to think about how we're going to load the case, and then we got to think about what are we going to do to provisionalize this? What kind of an interim prosthesis are we going to need to design, and who's going to be responsible for that fabrication? That's great if everything goes according to plan. So what happens if there's a hiccup, or maybe we can't get implants into a site that radiographically looked like it was going to be okay? So I'm going to need to think about contingency plans, and not just me, the whole team's got to think about what are we going to do if things don't work out the way we think they're going to. So surgical contingency plan and a restorative contingency plan. So on a case like this, if the implants were not able to immediately load them, then how are we going to deal with that? Because I've just taken the guy's denture away. He's not going to have any teeth while he's healing up. So I just want to have a plan for that. I hope that doesn't happen, but I need to have a plan for it. Additionally, we need to have a plan for how we're going to manage follow-up and complications. So if the patient calls up and they're wearing a provisional hybrid that was converted and immediately loaded, then the provisional breaks. Who do they call? The answer doesn't really matter right now, but we've got to have that conversation. The patient feels like there's swelling or pus, or a suture comes loose. The patient has more swelling than they think they should. How are we going to manage those types of complications? That's all the kind of stuff that I think we need to have in these conversations. Additionally, what are we going to do for maintenance so that we're all saying the same thing to the patient about not just the provisional prosthesis or the interim treatment, but ultimately the definitive restoration. What are we trying to tell the patient to help them in the best way that we can to keep things clean? And so this is actually a tepe brush from the table outside. And, I started using those in LA, and I feel like I'm selling that stuff. But if you haven't checked them out, they've got some cool designs for complex restorations like this. So I'm glad they're here. Someone's got to think about the components that are going to go into the case. And so if it's the day of surgery, the implants go in, and you're a surgical office and you've got a lot of multi-unit abutments or SRA type abutments, and you're going to be placing the abutments and then refer the case back to your restorative person, that's great. I need to know that so I don't order the components as well. You've got to have the lab involved in this. So am I ordering the components directly from the manufacturer? Surgeon's office going to order them, or are we going to rely on the laboratory to either order the components or custom manufacture components? But all that stuff adds into how much the case is going to cost, our expense for the case, and ultimately missing this step is where we can start bleeding profit. It'll really quickly start to add up. So this isn't the best, maybe, one solution for every single case. I hope it's not, because my belief is that every complex case like this, or really every case, it's important to treat those as individuals. And so I think it's important to have these kinds of conversations for any kind of an interdisciplinary case. In fact, you heard that from Robley and Curry. I think there's no better learning tool than sitting with the person that you're going to be working on this type of a case with. But if you look at this form, there's a lot of information on there. It's a little bit overwhelming. So when I showed it to the guys in the workshop, they're like, seriously, I got to know all this stuff? No, the key is you don't really have to know all of it. Because if we think back to what Martin said this morning about collaboration and about mentorship, this is a great tool to help people begin to get into that kind of a relationship with you, regardless of what your role is on the team. You could be even a technician. If my technician in 1995 had said, hey, this is the kind of information that we're going to need, game changer for me. So whether you decide you want to use this, awesome. I'm stoked. In fact, we've made it available as a Word document and as a PDF, so you can print it directly off your resource page. You can print it directly as a PDF and use it as it is, or my hope for it is you'll open up the Word document and start tweaking it and making it your own. So this is designed really specifically for edentulous arches, but I could have designed the exact same thing for like a single missing tooth, right? So, oops, sorry about that, guys. So phasing and sequencing is on the back page. And I want to make sure that you see that before we go, because phasing and sequencing, you know how we do our focus groups with you guys, and we try and figure out like where we're really screwing up, because that's what I feel like that's 80% of my job. But we also hear things that are going well, and we hear things that you're looking for, so we could be more helpful to you. And we did the same thing with a bunch of dental patients. And one of the things that the dental patients told us was, you know what, when I'm going to start treatment, the woman who shared the story was actually talking about endo, but this is the exact same thing. If I'm going to start treatment and I'm the patient, what's all involved on a case like this? How long am I going to be in treatment? And so if Liz asked her implant surgeon, like when am I going to be done with this? The surgeon's point of view might be, well, the implant's going to go in, I'll see you for a follow-up, and you're good to go. If she's just asking me as a restorative person, I might say, well, I just need to make an impression, and then we'll put the provisional or do whatever, but I'm giving her just really a limited point of view. And so what we heard in the focus group with patients was, you know, getting a root canal is not getting a root canal. Getting a root canal is, I woke up one day, had a toothache, I went to my general dentist, and I got diagnosed as needing a root canal. I went to the endodontist, and they started my root canal. I went back, they finished the root canal, and then I had to go back to my restorative dentist and have a restoration place, which took multiple visits. So this idea of, yeah, you're just going to need an implant or you're just going to need a root canal, for us, that means something. But to a patient, that, like, the context is totally different. And so understanding what we need to do for phasing or sequencing a case is really critical for helping patients understand what to expect, especially with complex treatment. And so we don't have time tonight to go through kind of all the steps of that, but what I'd encourage you to do is take advantage of this blank back page, and for a couple of cases with the other members of your interdisciplinary team, sit down, even a case like this, a simple, relatively simple single missing tooth, and list out every single appointment that you anticipate that patient will go through from right now until you can say, hey, you know what, I'll see you in 6 months. It's eye-opening. And it can really, really help us as a team get a little bit leaner and get a little bit more efficient, but for sure will help us help our patients understand what to expect.